Our ASH 2015 coverage continues in Orlando. I'm Thomas Baldrick, joined by Dr. Robert Hills from Cardiff University in the UK. You are an entertaining chap.
Oh, thank you.
You're welcome. Let's talk about this study of yours using Quazartinib to significantly improve overall survival in FLT3-ITD positive AML patients. How does this mutation status affect prognosis in AML?
Okay, so FLT3-ITD is probably one of the most common molecular mutations that you're getting in AML, and it's poor prognosis for you. And what happens is that it seems that you will have a tendency to relapse much sooner after your therapy, and even when you do relapse, your prognosis is then worse than people who don't have this mutation. There are sort of other areas with it. There are things like the amount of mutations, or the allelic ratio we call it, the level of the mutation in your system, and again, if you've got that to a high level, that's even worse for you as well. So it's not a good thing, but it is something that we are able to look at targeting. And so this drug, Quizartinib, is what they call a FLT3 inhibitor. And so it's actually aiming to sort of target the FLT3 and improve the outcomes in these patients.
So what did you do in the study with this drug?
Okay, so this study is looking at the results of a phase 2 study, which was called the AC220-002 study, which has been run in the past. But because it's a phase 2 study, there's no comparator group in there. All you get is the results from one group of patients who've been treated with this. And these are patients who have failed therapy twice, or they have failed after having had a stem cell transplantation as well. So that's fine, and they come up with a pretty good remission rate. They've got a 40% remission rate. They've got a median survival there of about 6 months. But the problem you've got with that is you don't know if that's good, bad, or just the same as you'd expect to see. So this study was trying to put those results in some sort of context. And the idea here is to compare it to a population-based cohort of patients. And in the UK, we've been running trials in AML for about 50 years. And in the more recent patients, we've started to look increasingly at the different sorts of molecular mutations that make up the disease. So we have a lot of follow-up on a very large cohort of patients who have got this mutation, and so we could replicate the situation, the eligibility criteria for this 002 study. And we did that, and then we adjusted for things that might be different. We tried to get rid of all the early deaths in the cohort that we had, because if somebody's in a pretty bad way, you're not going to want to put them into a trial. So those, there'd be a bit of selection going on. So we tried to make the outcomes in the MRC patients as good as we possibly could by throwing things out, throwing out early deaths. And then we compared it to the AC220 cohort from this 002 study. And we found that the hazard ratio, so this is the risk of death, the instantaneous rate of death, is halved with Quizartinib compared to the population you normally have, and that the median survival in the population is under 2 months compared to between 5 and 6 months on Quizartinib. So it's got limitations. It's not a randomized controlled trial, but it does start to tell you that this is a promising agent and certainly worthy of further investigation in a proper phase 3 trial, because this is not a cure, but these are pretty beat up patients. These have got pretty poor prognosis, and I think people would kind of like to take 6 months over 2 months any day.
Any day of the week. So do you feel like you were able to achieve the goal of putting all this into context?
I think so, as much as you ever can. I mean, it's always difficult to put it exactly into context, because the decision to enter a clinical trial is a partnership between the clinician and the patient, and sometimes the patient's family as well. So older patients particularly, or children, the family, it comes into it a lot more. So we can never get inside the head of the clinician, but we can do our best by adjusting for what we can measure. So it's not slam dunk, irrefutable proof that this is the next best thing, but it tells you that actually this is a player. And of course now this is moving forward into phase 3 trials. So they've got a Quantum R trial, which is a proper randomized trial in exactly this population, this second failure population, and that's about halfway through recruitment. So that's a company-sponsored trial. And I know that in the UK, for example, the MRC, National Cancer Research Institute AML Trials Group, we're looking at Quizartinib in 2 settings, in the older patient, in upfront therapy. So this is both in people who are unfit for intensive chemotherapy, but also as an add-on to standard intensive chemotherapy. So we're going to look at it there, and the company are looking at it in the setting that we looked at in the poster here.
Well, we wish you the best of luck with it. Thank you.
Thank you very much.
Cheers.
Thank you.